Welcome back to Diabetic Foot Files. It is 1:30 in the morning, and why am I up? For the oddest reason. Somebody was blasting Otis Redding Pain in My Heart around 1 in the morning, so somebody's feeling it tonight. I'm not mad at him. I like anybody who has soul, so I didn't even know people still listen to Otis Redding because he is good. Like, if you listen to Otis Redding, you got soul. Like, I am not mad at you. Sundays are meant for jazz. So, I mean, every day is jazz, but let's get into it. So, this is Diabetic Foot Files with Dr. G. And so, this episode, we're going to focus on who do you see first? Because, let's say you're on call, going to have multiple consults. I mean, they usually go with like first come, first serve, but, you have to figure out triage labs, limb or life threatening decisions, especially when it comes to diabetic foot ulcers. So, let's say you got three consults come in at the same exact time. So room one, foul smelling foot with black tissue. Room two has a small ulcer, but the patient has a fever. Room three is a callus and callus with no pain. Okay. So you can only see one first. So who do you choose? And what happens if you choose the wrong one to see first? So in diabetic foot care, you're not just treating wounds, you're actually prioritizing which are threats, right? And the hierarchy is one is life threatening. One is life threatening, right? Two is limb threatening. Three is functional threatening. And four is stable and maintenance. So the highest priority is if it is life threatening. Okay. So first, we see if there's systemic infection slash sepsis. So what are the red flags for that? If the patient has a fever over 38 degrees Celsius, if there's tachycardia if it's more than 90 beats per minute, hypotension, altered mental status, elevated respiratory rate. So, why is the fever a bad thing? Sometimes. So, fever means that the body has mounted a systemic inflammatory response to the infection. So, what's happening? There's pyrogens like IL-1, TNF alpha, prostaglandins that are trying to reset the hypothalamic thermostat. And the body raises the temperature to inhibit the bacteria growth and enhance the immune activity. And in a diabetic foot, remember, in diabetes, your immune system is compromised. So this suggests infection is no longer superficial. It often suggests that there might be osteomyelitis, abscess formation, or spreading cellulitis. And a pearl to always remember is that diabetics may be immunocompromised. So there might be an absence of a fever. So an absence of a fever does not rule out severe infection. Fever is bad, but no fever does not mean that the patient is safe, okay? Then with the tachycardia. Tachycardia is one of the earliest signs of systemic stress or sepsis. So what's happening is the infection increases the cytokine release and that causes an increased metabolic demand. And the heart rate rises to maintain the oxygen delivery and compensate for the vasodilation and possible fluid loss. And in a diabetic foot, you have onset of early sepsis, pain, stress response, hypovolemia from infection. So persistent tachycardia despite fluids is a red flag for worsening sepsis or septic shock. Now, hypertension. Why is that? Hypertension is usually a late and dangerous sign that may indicate septic shock. Unfortunately, I know this too well. It happened to my father. So what happens? Bacterial toxins causes massive vasodilations. The capillary leak fluid leaves the bloodstream, and the result is a decrease in circulating volume and a decrease in perfusion pressure. So if the patient is coming from the diabetic foot, right, it means that the infection is overwhelming the system. Organs like your kidneys, your brain, or heart are at risk. So hypertension plus infection means ICU level. And yeah, They couldn't get him in ICU or a bed. Okay, then. So that's the healthcare system here. The patient is now in a limb and life-threatening thing, but also be grateful if you're in a place that has really good health care, that acts and has beds for people who helped save the country, people who helped with our independence, people that if it wasn't for them, you wouldn't be here like that. But, not having a bed for a person like that or anybody who needs ICU, hmm, yeah, I don't know. But be grateful if you have a really great healthcare system, okay? So, next is altered mental status. People usually try to downplay, especially with the elderly, saying, oh, it might be dementia, or they're just, not it with it, or they say it's a stroke. But you gotta also rule out sepsis, right? If there's an altered mental status, that could be a bad thing because the brain dysfunction due to systemic illness is reflected in the brain as well. So what's happening? Stuff like poor perfusion to the brain, inflammatory mediators affect the neurotransmission, possible metabolic derangements such as hypoglycemia versus hyperglycemia, electrolyte imbalance, and sepsis associated encephalopathy. And, in a diabetic foot, signals like severe infection, possible sepsis or shock, or impending organ failure. So just remember, confusion in a diabetic patient that has a diabetic wound, treat as sepsis until proven otherwise, or stroke, whichever. But you know, I believe the more experienced the clinician is, the more better they're able to figure out which one. Okay. Now, elevated respiratory rate, one of the earliest and most sensitive signs of sepsis as well. So, what's happening in your body? Your body's trying to compensate for the metabolic acidosis. So, it's blowing off the carbon dioxide. So, there's increased oxygen to increase the oxygen delivery. So, they're trying to compensate for the metabolic acidosis. And diabetic foot, you know, could be sepsis, could also be diabetic ketoacidosis, could also be I have Otis playing in the background, forgive me, it's getting a little too loud. Lactic acidosis from poor perfusion. And a rising respiratory rate can show deterioration before the blood pressure drops. So, putting all that together, if you see any combination of this in a patient with a diabetic foot wound or anything, fever, tachycardia, hypotension, altered mental status, and tachypnea, you are no longer just treating a foot wound. You are treating a systemic infection emergency. And these signs are part of what we clinically recognize as systemic inflammatory response syndrome, SIRS, okay? And progression towards sepsis, severe sepsis, to sepsis shock, okay? So, what is the likely diagnosis of something causing this? Necrotizing fasciitis, severe sepsis from an infected ulcer, or gas gangrene? Other clinical signs are crepitus, rapidly spreading erythema, skin discoloration like purple or black, severe pain, or paradoxically, no pain. But sepsis is a big deal because it's the point where the infection stops being localized, it turns into a whole body life threatening process. And in the context of a diabetic foot, this is where we save a limb, but this is become life salvage now. Okay. And you have to also remember, sepsis is a big deal. It's an overreaction. It's not just an infection. It's an overreaction. The sepsis isn't just the bacteria spreading. It's dysregulating the host. Okay, so this means that the immune system releases massive amounts of cytokine, widespread inflammation, tissue damage, blood vessels become leaky and dilated, and the body essentially damages itself while trying to fight off the infection. And, it causes organ failure. Sepsis can shut down multiple organs. Unfortunately, I know this too well. Happened to my dada. So, kidneys, you can get acute kidney injury, brain confusion, coma, lungs, respiratory failure, ARDS, heart, decreased cardiac output. This is called multi-organ dysfunction syndrome, MODS. And it can escalate fast. A patient could go from stable to septic shock within hours. Mortality increases significantly with delayed treatment. Keyword is delayed treatment, delayed diagnosis, delayed recognition of symptoms, delay attention to details. Okay? Anytime somebody comes into the hospital, anytime somebody comes in for medical treatment, just take it seriously. Okay? Don't just downplay it and be like, oh, off you go. You are stable to go home because I think it's something else. Please let's not do that, okay? High mortality rate. Sepsis does have a high mortality rate. Sepsis is about 10 to 30%. Septic shock can exceed to 40 to 50%. That's why early recognition plays a huge role, and that's why people shouldn't cheat on their exams, okay? Because if somebody's cheating on their exams and they end up still being a doctor, those are usually, the people that end up not helping out, okay? That's the whole point of studying. That's the whole point of the exams being hard so that you can use your brain when the situation happens instead of somebody else using their brain who actually studied, okay? I might still have a grudge against people for delaying and misdiagnosing certain family relatives, but God says forgive, right? So now, sepsis, again, let's say first you have to suspect or confirm infection. So in our world, we're thinking diabetic foot ulcer, abscess, osteomyelitis, neck rash. Okay. Evidence of organ dysfunction. They use something called the SOFA score. So an increase of equal 2 points equals sepsis. So SO SOFA score looks at your respiratory, your coagulation, like your platelets, your liver, your bilirubin, your cardiovascular, like your BP and the vasopressors, your CNS, so the Glasgow Coma Scale, and renal. And a quick bedside tool is helpful. So, you can use it clinic ER or the bedside. The QSO FA criteria. So if the respiratory rate is equal to or greater than 22, alter mental status, and a systolic blood pressure greater than or equal to the 100. Okay, 2 or more means high risk of sepsis. Septic shock. This is the worst stage. Okay, septic shock. Sepsis plus, this is like progressing. Persistent hypertension despite fluid requires vasopressors and elevated lactate. Okay, greater than 2 mmol per liter. This is a circulatory collapse. So when the infection hijacks the bloodstream, the body stops fighting smart, the body starts fighting blindly, and this is when the organs fail, the pressure drops, and time becomes tissue. We always tell people that. And you know, I actually once had a person, a healthcare provider, not certified now, just I wouldn't say I wasn't, battling with the person, but I was just telling them what they were doing was wrong, okay? Because they were treating this person's wound for, months, whatever, and they didn't even know half of the things that I told them, and they were like, "Oh, I'm sorry. I didn't know." And I was like, "Well, you're the one who's coming at me, trying to tell me that this is wrong, but this protocol is wrong, but it's actually helping and healing the wound." And then I was just like, "You have to remember time is tissue." And she was like, "Oh, wow, I never heard that before." I'm like, "Hmm. Okay, cool." And y'all just stop. I have great mentors. Y'all will hear me constantly say that. But I had a great mentor that said, pride is most often misplaced. Medicine is not the place as a clinician or physician or a healthcare professional to have pride. It's not about you. It's about the patient. Okay, so if you need to ask somebody else, if you're even in doubt about something and to ask somebody else and be like, hey, could it possibly be this? Could it possibly that be that? It's not about your ego. It's about treating the patient. I've seen it multiple times where an ego has allowed the tissue to be damaged over time because they didn't contact the right person, didn't ask the right person, just wrong diagnosis. That's people. That's the world. But that's why anatomy is important. That's why it's good for patients to advocate for yourself, advocate for your family relatives. So, what type of labs do we draw? Forgive me, it's the middle of the night. So, what type of labs do we draw? CBC with differential, elevated white count. Okay, sometimes the elevated white count is sometimes a normal thing in immunocompromised patient, but Please keep an eye out for that. Lactate. Lactate is actually a marker for tissue hypoxia and sepsis. CRP and are inflammatory markers. CRP rises faster. Blood cultures. You should do blood cultures times 2 before antibiotics. Remember that. And CMP, we need CMP definitely for kidney functional, just in case for antibiotic dosage, and procalcitonin that helps identify bacterial sepsis. So why does procalcitonin help identify bacterial sepsis, PCT? Procalcitonin is actually a powerful identifier of bacterial sepsis because it behaves very differently in bacterial infections versus other types of inflammation. It's not just another lab, it reflects the biology of how the body recognizes bacteria. So, what is actually procalcitonin? Procalcitonin is the precursor of calcitonin. Calcitonin is a hormone normally made in the thyroid. Under normal conditions, procalcitonin levels are very low. In a healthy person, it's almost non-detectable undetectable. But what happens in a bacterial infection? When bacteria invades, the body releases endotoxins, which are from the bacteria, and cytokines like IL-1, TNF alpha, IL-6. And these signals trigger a mass production of procalcitonin throughout the body. So, along your lungs, your liver, intestines, not just your thyroid. And the result will be a rapid rise of procalcitonin, which will be within 4 to 6 hours. And it peaks around 12 to 24 hours. Why is it specific for bacteria? The key difference is that bacteria infections stimulate procalcitonin production. So there will be a high procalcitonin. Viral infections, in viral infections, there's a increase in interferon gamma, I believe. And this actually blocks procalcitonin production. So that's why procalcitonin actually stays low in viral infections. So that's why procalcitonin labs do matter in matter of sepsis because it strongly suggests bacterial sepsis. So it helps distinguish from viral illness or non-infectious inflammation like trauma, surgery, or autoimmune disease. Okay. So in diabetic infections, procalcitonin can actually help us answer a critical question. Is this local wound or is this a systemic bacterial invasion? And so if the patient has a high procalcitonin, it suggests that there's a deep infection, abscess, osteomyelitis, bacteremia, a progression towards sepsis. And if there's a low procalcitonin, it suggests like possible localized infection or non-bacterial cause, okay? But also it helps track severity. So the higher the procalcitonin, the more severe the infection. Rising level means worsening infection. Falling levels means it's responding to treatment. So you can trend and help guide the antibiotic duration and the critical improvement. So what are some of our limitations when it comes to procalcitonin? Procalcitonin is not perfect. Can be elevated during major trauma, surgery, severe burns. So it may be also falsely low early on in localized infections and immunocompromised patients. So you always have to interpret the clinical signs and other labs like white blood cell count, lactate, CRP, okay? But procalcitonin is like the body's bacterial alarm system. When the bacteria invades the bloodstream, it sounds off loudly. But when it stays quiet, you should question whether you're really dealing with a systemic bacterial enemy, okay? And, you have to remember this type of patient, you don't wait. Broad spectrum IV antibiotics, surgical consult, and possible OR within a few hours. Okay. You always have to ask the patient whenever you suspect, forgive me, a little tongue tied, sepsis, MPO. When's the last time you ate? Then we can take you to the OR and get anesthesia on you right away. So, next. If you suspect a deep infection or osteomyelitis, what are the clues? Ulcer that probes the bone, a chronic wound that has been there for more than 2 weeks, mild systemic symptoms, and local warmth and swelling. So let's say the ESR is greater than 70. That's a real strong osteomyelitis indicator. CRP elevated, white blood cell count might be even normal. X-ray, you might see changes, okay, like bone erosion, but that's usually in late osteomyelitis. Remember, if it's early, it takes about 2 weeks to show. MRI is gold standard when it comes to imaging, but bone biopsy. is our actual gold standard, right? And clinical move, debridement, targeted antibiotics, and possible surgical resection of the osteomyelitic bone. Okay? Now, let's think about ischemic limb, like a silent emergency, because critical limb ischemia is not a joke. It's a high priority. It's a big deal. Get vascular on them stat if you're trying to save the limb. Okay. So pale, dusky foot, cold skin, absent pulses, pain at rest if sensation is intact, non-healing ulcer. So tests that we'll do is a ABI, toe pressure, a Doppler ultrasound, a CTA or MRA. Okay, vascular consult ASAP, revascularization per vascular recommendation like angioplasty or bypass, because you cannot heal if you cannot perfuse. Now, another example, let's say something is moderate priority, it's infected but stable. So it's a localized infection. The redness is less than about 2 centimeters around the ulcer, mild drainage, no systemic symptoms, CBC, CRP is might be elevated, wound culture after debridement. Remember, do that after debridement so you can get the real cause of the bacterial infection, okay? Clinical moves, oral antibiotics, local wound care, offloading. The patient is stable, but you have to remember it can escalate very quickly. And then, let's say the last one is a nice, clean chronic ulcer. There's no redness, there's no drainage, there's granulation tissue present. Often not urgent, okay, but they might have osteomyelitis because it's been chronic and open for a while. Definitely take imaging, CBC, get your baseline labs, debridement, wound culture, probably have to offload the patient either in a total contact cast or removable cam walker, and appropriate wound healing. But for me, you have to prioritize. That's what I even tell my family relatives. I say, when it comes to problem solving, we have to prioritize what's the most important one right now. Okay? And the whole point is to save a life and to save a limb. So in our triage ladder, let's just remember highest to lowest priority. And just remember, we just want to save the life, make sure save the limb, and stabilize the patient, right? Sepsis, necrotizing infection, that's the highest priority. Gas gangrene, critical limb ischemia. All these I just say as number one, okay? Osteomyelitis, we could fix that. Moderate infection, stable ulcer, callus. Let's say they have callus. Prevention is better than cure, right? And remember, key markers of our labs that help tell us what's going on, white blood cell count, high. If it's high, most likely infection. If it's normal, honestly, if the white blood cell count is normal and the patient's diabetic, that still does not give you the clear go ahead. No. Okay. CRP, like we said, rises quickly in acute inflammation, forgive me. ESR is slow but a strong indicator of chronic infection like the bone. And then your lactate. Okay, so let's say the lactate is 2, you should be concerned. If the lactate's 4, that is critical. So lactate is one of the most important markers in sepsis as well because it reflects tissue hypoxia. Like I said earlier, tissue hypoxia and poor perfusion. So basically, whether your body is getting enough oxygen at the cellular level. Lactate is produced during anaerobic metabolism. So when the cells don't get enough oxygen, they switch from aerobic to anaerobic metabolism, and lactate ends up being a byproduct. And lactate is rising in sepsis because in sepsis, the blood vessels dilate, which causes the blood pressure to go down, right? The capillaries leak, which reduces circulating volume, and microcirculation fails. So oxygen delivery does drop in the tissues, and the cells are forced into a low oxygen metabolism, which causes the lactate to rise. So a lactate of 2 or equal or a little bit greater than 2 is concerning. These are early signs of impaired perfusion. The patient may still look okay clinically, but underneath the organs are not getting enough oxygen. And this is often called occult shock. Okay. So in a diabetic foot could mean infection is starting to go systemic and early sepsis may be already developing. If the lactate is greater than or equal to 4, critical. This means this is a strong indicator of severe tissue hypoxia associated with high mortality. Okay. And red flag is for septic shock, impending organ failure. Even if the blood pressure is normal, if the lactate is 4, treat aggressively. Lactate is powerful, like we said, because lactate rises before hypotension. This is a silent warning sign. It reflects severity. The higher the lactate, the worse the perfusion. Strong correlation with mortality, and it guides the treatment. You don't just check it once, you trend it. So, if the lactate is going down, that means the patient is improving. If the lactate is going up, that means they're worsening perfusion. Lactate clearance is a key treatment goal. And in a diabetic foot, like we said, high lactate means infection has gone beyond the foot. It's more systemic now, it's systemic compromise. Think deep infection, necrotizing infection, sepsis. And, lactate also rises with strenuous exercise, liver dysfunction, because they can't clear the lactate. And certain medications can actually raise lactate. But in a sick diabetic patient with a foot that is compromised, always assume elevated lactate means perfusion problem until proven otherwise. So, because lactate is the voice of suffocating tissue. When it rises, it tells us that the body is starving for oxygen. And if you don't act fast, the cells die. And like we said, procalcitonin helps confer bacterial infection, and hemoglobin A1C is our long-term control of the blood sugar. So, what are some common mistakes? Treating appearance instead of severity, ignoring systemic signs, delaying imaging, not checking the vascular status, and waiting too long for surgical consult. So, in conclusion, when it comes to diabetic foot ulcers, time is tissue, and tissue is limb, and limb is life. Okay, that sounds like a little Dr. Seuss thing, but keep that in mind. The difference between saving a foot and losing a patient is often just one decision. And, you know, who do you choose to see first? So this is Diabetic Foot Files. It's 2 in the morning. Otis Redding is playing in the background. And this is Diabetic Foot Files, where clinical instincts meets real world consequences. I'm Dr. G. And take care of your feet because they take care of you.